Hereditary unconjugated hyperbilirubinemia. So like we're gonna look at the table and then do whatever is possible. Okay. So the feature in type 1, type 2 Crichton-Rajan-Gilbert syndrome, total serum bilirubin in a milligram per deciliter is usually more than 20 in case of type 1, usually is less than 20 but more than 6 in case of type 2. In Gilbert syndrome, it's typically less than or equal to 4. In all these cases, we will see jaundice because everything is above 2.5. Okay. Other response to phenobarbital, no response in case of type 1, decrease bilirubin by more than 25 percentage, decrease bilirubin to normal in case of Gilbert syndrome. Kernicterus is usually present in case of type 1. It's rare but can be present in case of type 2, but it is not present in case of Gilbert syndrome. Bilirubin glucuronidase transferase activity, typically its absence of 0 percentage, markedly reduced in case of type 2, 0 to 10 percentage of the normal, reduced typically in the range of 10 to 33% of normal. Activity is retained. Okay, inheritance autosomal recessive is Crigler-Najjar syndrome type 1 and type 2. Gilbert syndrome is autosomal dominant. So this is all the contrasting features. Moving on to Dubin-Johnson syndrome. So like the differentiating features, first we will see. So congenital conjugated hyperbilirubinemia, we have Dubin-Johnson syndrome and Rotar syndrome. Oral cholecystography is done. The oral cholecystography pannaga, the GB is not seen in case of Debin-Johnson syndrome. That is the gallbladder, whereas gallbladder is seen in case of Rotar syndrome. Both are autosomal recessive conditions. Both are conjugated hyperbilirubinemias. Abnormality in case of Debin-Johnson syndrome is that there is reduced canalicular excretion of organic anions, including bilirubin. But Rota syndrome is a storage disorder, so there is defective intrahepatic storage of bilirubin. Clinical features in Debin-Johnson syndrome, it's a DJ, okay. So DJ usually keeps, jumping here and there. So there's no symptoms. There are usually mild symptoms, so no treatment is necessary. In rotor syndrome also same thing. It's like rotor is rotation like a wheel. Wheel never stops, right? So mild clinical features, no treatment is necessary. And then BSP is there. BSP is bromsulfaline. Okay, bromsulfaline. The reflex is seen in case of DJ syndrome. No reflex is seen in case of rotor syndrome. So, based on any investigations which we are going to diagnose or distinguish between Dubin Johnson and Rota syndrome is that in oral cholecystography, the gallbladder is not seen in Dubin Johnson, it is seen in Rotar syndrome. BSP, that is bromosulfaline excretion, reflex is seen in case of DJ, because like DJ is puking a lot, but there is no reflex in case of Rotar syndrome. So, this is about all the differences between all these things. Okay, so thank you.